Primary care, the way it's built in this country, was never designed to keep you healthy. It was designed really to manage once you're already sick. Now, that's not a conspiracy. It's not malpractice. It's really just math. 15 minutes. A panel that hasn't changed in over 20 years, a reimbursement model that pays for prescription, not a conversation, and the result is predictable. You turn 40, then 50, and somewhere in there, your chart starts filling up with refills, statins, maybe metformin. Nobody sat you down and asked why these things are happening.
Welcome to Health Decoded, your number one source for real health information, with your hosts, Dr. Alessi and Matt Tack.
Welcome back to Health Decoded. I'm your host, Dr. Alessi, founder of Ascend Functional Health. And if you only ever listen to one episode of this show, just make it this one, because everything else that I've covered, the biomarkers that your annual physical skips, the reason that your last 3 doctors couldn't fix what was actually wrong with you, the concept of cash pay medicine not being the luxury that you wanted it to be, all of this sits downstream from one central idea. Primary care, the way it's built in this country, was never designed to keep you healthy. It was designed really to manage once you're already sick. Now, that's not a conspiracy. It's not malpractice. It's really just math. 15 minutes. A panel that hasn't changed in over 20 years, a reimbursement model that pays for prescription, not a conversation, and the result is predictable. You turn 40, then 50, and somewhere in there, your chart starts filling up with refills, statins, maybe metformin, something for blood pressure. Nobody sat you down and asked why these things are happening. They just started managing you based on numbers. And so I actually want to make a case today, plainly and with the proper information, for a different model. Not functional medicine as some add-on that you get after everything else fails you. Not functional medicine as the backup plan, but functional medicine as your actual primary care, the front door, the place where prevention happens before you ever need a prescription pad. If you've listened to this show before, you know that I've talked about biomarkers, about why standard testing misses things, about clinical failures. Today is going to be different. Today isn't about a symptom or a marker. It's about an entire model. What primary care is supposed to be doing for you and why almost none of it actually does. Everything else we've covered fits underneath this. So let's just get into the topic here. Here's what nobody explains to you, okay? Primary care in the insurance-based system isn't built around you. It's built around a volume, a set number. The average primary care visit in this country runs somewhere between 13 and 18 minutes. In that window, your doctor has to review your chart, address whatever brought you in, order anything that's urgent, refill anything that needs refilling, and document enough to justify why they're billing codes to a payer who is auditing every minute of that visit after the fact. There's no structural room in that window for answering the question why. Why is your fasting insulin creeping up year over year? Even if your doctor genuinely wanted to have that conversation with you, there's no wiggle room built in for thinking outside of the box. So the system does what any system under those constraints does. It optimizes for the fastest legible action. And the fastest legible action almost always is a prescription. Not because your doctor's lazy or doesn't care about you. I think majority of doctors actually genuinely care. The overwhelming majority of primary care physicians that I've worked alongside are actually exhausted, overbooked, and carrying patient panels in the thousands and genuinely doing their best inside a structure that was never built for root cause work. The prescription is the tool that the system hands them. It's the tool that they've been trained to use. So the prescription is what gets used. Think about what that means compounding over a couple of decades. Your fasting glucose drifts up a little every year. 92, then 96, then 101. Nobody flags this pattern until you cross that arbitrary line into pre-diabetic, and even the intervention is usually a follow-up in 6 months, not a conversation about the 15 years of gradually rising insulin resistance that got you there in the first place. Your blood pressure maybe has been creeping up from 118 to 128 to 138 across your 30s and 40s. At some point, again, you cross this arbitrary threshold that basically on a chart, and the answer to that is a pill. Not to look at your sleep architecture, maybe your stress load, maybe your mental health, maybe your sodium to potassium ratio, or the visceral fat around your organs that's been quietly accumulating while your scale weight still looks fine. None of that happens because standard care doesn't understand that root cause matters. Every physician learns pathophysiology. It happens because the system isn't built to pay for the time that root cause work actually takes. You cannot run an elimination protocol in 15 minutes. You cannot review 4 months of continuous glucose data, map a hormone panel against a symptom timeline, or unwind a decade of HPA axis dysfunction in a visit built for Medicaid refill and acute complaints. The visit length isn't an accident of scheduling. It's the design constraint that determines everything downstream of it, including which tool was going to get reached for first. Here's the version of this that maybe hits differently. If you're running a company or sitting inside a senior operating role or you're some high-level performer, you would never let a critical system in your business get monitored only when it throws an error. You have dashboards, you have KPIs, leading indicators. You catch these drifts in a supply chain, a burn rate, a churn curve, long before it becomes a crisis. Because waiting for the lagging indicator to fire is how companies die. Think of it in a more simple example. The check engine light in your car going off. You take it in when that check engine light comes off. That's the symptom. Now, if you just wait for the car to break down, that's not being preventative. That's waiting for disease, injury, crisis before taking action. And yet, the majority of people that I sit across with they have more instrumentation on their quarterly numbers than they do on their own metabolic health. Not because they don't value it, but because the default healthcare model has never really offered them a leading indicator. It offers a physical once a year that checks whether you've already broken something or not. And if you're managing a chronic condition, you've lived the other side of this same gap. You've had labs come back normal while you feel measurably worse every single year. That's not you imagining it, and it's not in your head. It's because normal on a standard panel is a population reference range, not a marker of your actual function. It's because normal on a standard panel is a population reference range, not a marker of your actual function. And nobody in a 15-minute visit has the time or the tools to ask what your normal used to look like before things started sliding, or to look for the 12 markers outside the standard panel that would actually explain what you're feeling. This is the gap. Not a villain, not a conspiracy, a structural, economic-based gap between what primary care was built to do and what actually keeps a person out of the pharmacy aisle for the next 30 years. And once you see the gap clearly, once this clicks, the next question really answers itself. What would a model built to close it actually look like? That's what we call functional medicine, as the actual front door. So what does it look like to build primary care around prevention instead of management? This is where functional medicine stops being the thing you try after everything else fails and becomes what it should have been from the start. Your front door into the healthcare system, not a specialty referral 3 years and 4 prescriptions too late. Mechanically, the difference comes down to 3 things: time, data, and sequencing. Time first. A functional medicine intake is not 15 minutes. On average, I spend 60 to 90 minutes, sometimes longer, across multiple visits because the entire model depends on actually understanding you as a whole system before anything gets ordered. Your family history, childhood patterns, possible trauma, things that maybe psychologically have happened, your sleep architecture across the past several years, your stress loads and how it's changed with your career and family, the actual timeline of when your symptoms began relative to specific life events, not just how long has this been going on. You cannot find a root cause in a rushed conversation. Root cause work is deliberately slow on the front end so that everything after it, such as testing, interventions, and the results, move faster and more precisely than the trial and error approach that we see in standard medicine. Second, data. We're not working off the same 8-marker panel that you've had every year since college. Fasting insulin, not just fasting glucose, because insulin resistance shows up in the insulin number 5 to 10 years before it shows up in your glucose number. HSCRP, if you've ever listened to the show, I talk about this all the time, for vascular inflammation. This is often elevated years before it can manifest as a cardiac event. A full thyroid panel, TSH, free T3, free T4, reverse T3, and antibodies. Instead of just TSH, does the thyroid work, in isolation, which misses a meaningful share of actual thyroid dysfunction. Comprehensive and full sex and adrenal hormone mapping, gut function, microbiome markers, micronutrient status. The question we're asking isn't, are you sick? It's, where is your physiology trending and how far upstream can we catch it before diagnosis becomes a thing? And the third piece is sequencing. And this is the piece that standard care is structurally incapable of. Regardless of any individual physician's intent or skill level, we address root cause before we reach for suppression. If your fasting insulin is climbing, the first move isn't a medication that lowers the glucose number while the underlying insulin resistance keeps progressing quietly underneath. It's not even going to be a supplement. Not even going to just take a natural medicine approach. The first move is identifying why insulin resistance is developing in the first place. Sleep debt, chronic cortisol elevation, a buildup of visceral fat around your organs, meal timing and composition, declines in muscle mass, and intervening at that level. Sometimes medication is still the right tool. Sometimes supplementation is the right tool, and we use it when we need to. But it becomes a deliberate decision made with full information, not just a reflexive default because it's the only lever that we had time to pull in a 15-minute visit. This is what primary care should mean, not the specialist you eventually see after the diagnosis already landed, not the functional clinic that you stumbled on over Facebook after conventional medicine has run out of ideas. This should be the place you start before there's anything left to manage. So one objection that I hear, and I hear this constantly, so let me just address it rather than dance around it or pretend this doesn't exist. People say this sounds like it's going to take a lot more time and cost a lot more money than what I'm doing right now. And both of those things are probably true, and I won't pretend otherwise. A 90-minute intake does cost more time up front than a 15-minute visit. That's just true. Comprehensive testing does cost more than the 8 markers that you get on a panel. That's also true. But if you've listened to the economic conversation that we had a few weeks back, you know why I don't shy away from that. Because cost more upfront and cost more are two different things. And standard care only wins on the first one. The real comparison isn't this year's testing bill against this year's copay. It's this year's testing bill against 30 years of prescriptions, dose escalation, secondary medications to manage the side effects of the first ones, and the medical costs of whatever eventually develops because you did not address the root cause in the first place. And that's the concept between cost and investment. Functional medicine, preventive care is an investment, not a cost. Medications every year for the rest of your life, that's a cost. That's something you don't want to pay for. Prevention can be expensive today, but cheap over a lifetime. Management is probably cheaper today, but becomes extraordinarily expensive over a lifetime, and not just financially, but in the things you have to give up, in the time lost, all of that. And almost nobody does that math until they're the one living on the inside of it. It's rare that somebody nowadays is going to make that decision until they've felt the repercussions of that, unfortunately. And so, sorry, I got a little heated there. This functionally is what we built Ascend Total Care to be, not some add-on membership, not just some concierge upgrade that you bolt on to the same 15-minute model. This is a genuine replacement for what your primary care relationship should have been doing all along. Comprehensive testing on the front end, direct access to your care team as things move and change, and a relationship built around catching drift years before it comes a diagnosis instead of managing this diagnosis for the rest of your life. And the most pressing piece is staying preventative. It's not just a one-time event. So it's built on lifestyle medicine and real patient education as ongoing staples of the program, not just a binder you get on day one and you never open it again, because the whole point is that you understand your own physiology well enough to actually run it yourself between visits. If any part of what I just described sounds like something you've been missing from your own care, it's worth the conversation. There's no pressure or sales pitch, just an honest look at where you actually stand. Now, I want to walk you through kind of a composite case here. This is a blend of patterns that I see constantly across this patient population. This isn't just one person's actual chart, so I can't be specific about the mechanism without, infringing on anyone's privacy. And again, kind of a disclaimer here. This is a case, a composite illustration built from patterns. This is not an actual case. I'm describing a process here, not promising any results, not prescribing any medications. I'm not making any recommendations here. You obviously need to have your own information, your own evaluation done for any of this to apply. Again, just a composite illustration here. Picture a 47-year-old, fasting glucose is sitting in the low hundreds, not technically diabetic, but high enough that the standard visit will flag pre-diabetic and schedule a recheck in 6 months. Blood pressure around 134/86, borderline enough that a lot of primary care physicians would open up the conversation about a low-dose ACE inhibitor at the next visit if that number doesn't come down. LDL cholesterol elevated enough that the standard next step per most conventional guidelines is a discussion about a statin medication. On this trajectory this person is on, they are roughly 12 to 18 months and 3 separate prescriptions away from a chart that gets labeled well managed for the next 30 years. Now, flip that script. Here's what a root cause intake find instead. On the very first visit, fasting insulin nearly triple where it should be. The earliest, most sensitive marker actually for developing insulin resistance, and a marker that essentially never gets ordered on the standard panel. A cortisol pattern that's flattened across the day instead of showing the healthy morning peak. This is consistent with years of poor sleep, chronic low-grade stress, all very plausible, giving a demanding role and a habit of treating 5.5 years with 5 hours of sleep as a badge of discipline rather than a warning sign. Visceral fat elevated on a body composition scan, even though the scale weight itself looks entirely unremarkable and would have never really triggered a conversation on its own. None of the 3 numbers on the standard panel, those are glucose, blood pressure, and LDL, are actually even the problem. They are downstream symptoms of one upstream pattern: chronic stress, insufficient sleep, and rising insulin resistance that is compounded quietly for probably a decade before any of those numbers actually cross a threshold that would be diagnostic. I hope you're understanding the picture here. And so the intervention itself isn't really exotic. It's not anything extreme. Sequencing protein and fiber at meals to blunt that glucose and insulin spike. Optimizing sleep, a protocol built around actual circadian rhythm and an anchor, consistent wake-up time, consistent morning light exposure, a wind-down routine, not just generic instructions like try to get more rest. Targeted resistance training to rebuild muscle mass as a metabolic reserve, because muscle is one of the most effective insulin-sensitizing tissues in the body. Direct work on the cortisol pattern itself, because you can't out-diet or out-work out a nervous system that is stuck in a fight-or-flight response. None of that I just described requires a prescription, but all of it addresses the actual mechanism that was left alone and going to eventually require a prescription. Worked through consistently over a period of months, this is the kind of pattern where we frequently see fasting insulin begin to normalize, blood pressure settle into a range that no longer will trigger the medical conversation, and an LDL that improves enough to meaningfully change the overall cardiovascular risk calculation. Sometimes removing the near-term need for medication that was on the immediate horizon. Sometimes even reducing someone's dose requirements for patients who are already on something and working with their physician to reassess. And I want to be precise here because this matters more than almost anything else I'll say today. This is not the outcome for every patient. It's not a guarantee. Some people, because of possible genetic predisposition, family history, or how far a condition has already progressed before we see them, they may need medication, regardless of how well the root cause gets addressed. And in those cases, medication is the correct tool, not a failure of the process. The point of this was never to never take medication. The point is that almost nobody is ever given the chance to find out whether they need it in the first place. And that's what integrative health is as well, working alongside your physicians to understand that, hey, you're on this medication, something that you do need because things have gotten to that point. How can we address other things that are going to likely pop up? How can we prevent secondary medication use due to the side effects of the primary medication use? That's the important piece. And now, before we get to why this matters, let me give you something practical, and then we'll wrap this up. A handful of signals that, in my experience, show up years before anything crosses the diagnostic line on a standard panel. Not a diagnosis, just a pattern worth paying attention to. Things to look out for: energy that dips hard in the early to mid-afternoon, regardless of how much you slept the night before. That's frequently an early signature of blood sugar dysregulation. Your body swinging through a glucose and insulin spike and crash cycle that hasn't yet shown up as abnormal fasting number, because fasting glucose is often the last thing that moves. Waking up at 2 or 3 in the morning, wired, unable to fall back asleep for 20, 30 minutes, even though you fell asleep fine. That's a classic cortisol disruption pattern. A nervous system that hasn't learned to fully stand down, showing up in your sleep architecture. This is years before it shows up as a diagnosable condition. Weight that's stable on a scale, but a waistline that keeps creeping, or clothes are fitting differently through the midsection specifically. That's often visceral fat accumulating around your organs while your total body weight stays flat. This is one of the more dangerous patterns precisely because it's invisible on the one number that most people actually track, which is a weight on a scale. Another one is brain fog, slower mental gear shift by mid-afternoon. You think you're just getting older, or I'm just kind of tired. Sometimes it might be age, but far more often in the patients we see, it's some combination of blood sugar swings, thyroid dysfunction, and really something that a normal panel just will not catch or will call fine, as well as the sleep quality that never gets deep enough to actually restore you. None of these things on their own mean something is seriously wrong. But if 2 or 3 of them have been quietly true for you for the last several years, that's not just getting older. And it's not just something you should wait on until it becomes a number. That's exactly the window where root cause work has the most leverage, because nothing has fully tripped yet. However, you're starting to feel those symptoms, those check engine lights come on. Time to address. So if you're a high performer, if you're running a company or you're operating at some high level, here's the number that should genuinely bother you. It isn't the medication itself, it's the trajectory. One prescription at 45 statistically predicts more prescriptions by 55 and more again by 65, because the underlying pattern that produced the first one was never addressed, only suppressed, and it kept quietly compounding underneath the medication the entire time. That's not just a future health cost sitting somewhere down the road. That's a compounding tax on your energy, your recovery, capacity, your cognitive sharpness, landing in exactly the years where you're supposed to be operating at your peak. You would never accept that kind of unaddressed structural debt anywhere in your life, in your financial life, in your business. There's no good reason to accept it in the one system, your own physiology, that every other part of your performance actually depends on. I think about executives that I work with who came in already on some low-dose statin or an early blood pressure medication, convinced that that ship had sailed. The medication was just the cost of being 50 and successful. In more cases than not, once we address what was actually driving the numbers, the conversation with their own physician shifted from let's increase my dose to let's see if we can get off this at all. That's not a guarantee. Please don't take it that way. And I said that plainly a few minutes ago, but it's a conversation almost nobody gets to have, because almost nobody ever looks upstream on the prescription in the first place. And the truth is, almost nobody advocates for themselves. The doctor tells them what to do and they do it. Nobody thinks outside the box for themselves or says, is there another way? And that's what I'm here for, really. As a doctor, I'm an educator. My job is to do no harm. So I need to tell you that you need to be an advocate for yourself. If settling for medication to manage disease is what you actually want, do it. Perfect. That's you advocating. But if that's something that doesn't sit well with you and you want other options, you're just not sure what they are, advocate for yourself. Learn, explore, get educated. Talk to somebody else. Because if you spent years managing a chronic condition, here's what I want you to hear underneath everything I said today. The goal was never less pills as some kind of trophy to hold up. The goal is getting your actual function back, energy, mental clarity, the version of you that existed before this slow accumulation of symptoms quietly became your new normal. The version of you stopped noticing because it happened so gradually. For a lot of people, needing fewer prescriptions ends up being a side effect of that broader shift. Great, but it's not the point of it. I'm not here to get people off meds, but if that happens, fantastic. It's a meaningful side effect worth naming because every medication you genuinely no longer need is one less thing your body has to process every single day, one less interaction to manage across everything else you're taking, and one more piece of real evidence that you actually addressed the root cause instead of just muted it. Do this for me. Picture yourself at 60. In one version, the default version, the one that most people slide into without ever really choosing, you're on the trajectory most people end up on. 3, 4, maybe 5 medications, each one added a few years apart from the last, each one managing a number instead of a cause, because nobody along the way ever sat you down and asked why the numbers kept moving so fast in the first place. In the other version, you're the person whose labs make your friends, doctors pause and comment on how remarkable they are for your age. Not because you're lucky, because of your genetics, but because somewhere in your 40s, you stopped accepting that we'll just manage it is the only option on the table. And you started asking yourself, why? Why is this actually happening? Why do I feel this way? Why are my markers trending in this direction? That second version is what primary care should have been offering you the entire time. And it's what we built Ascend Total Care to actually deliver. Comprehensive testing that goes past your standard panel, real root cause investigation, and a care team that treats prevention as their primary job, not the upsell tacked on to the end of a visit. Lifestyle medicine, patient education sit at the center of that, not the periphery, because the goal was never to make you dependent on doctors for 30 years of visits. It's to hand you the tools and the actual understanding of your own physiology so that staying preventative becomes something that you can carry yourself with us as the backstop, not the crutch. If today's episode described a gap that you've been quietly feeling for years, but you could never quite put it into words, the next step is pretty simple. Book a discovery call with my team. We'll look at where you actually stand right now, no obligation attached, and we'll figure out together whether this is the front door into your own health that you've been missing. If not, at least we get to have a conversation and you can learn something. That's the case, laid out as plainly as I can make it. Not functional medicine as the alternative, but not functional medicine as the thing you try after everything else has failed. Functional medicine as primary care, the way primary care should have worked from the very beginning. Again, if this is something that hits home for you, share this with someone who needs to hear this message. That's the only way that we're able to spread the positivity of what we're doing, and not just us, but in general. Functional medicine, not just standard primary wait for things to go wrong medicine. Please follow the show, like the show. That's how we grow. That's how we're able to help more people. Again, if this is something you need help with or someone you know, book an appointment. Happy to talk through this with you. I'm Dr. Alessi, and I look forward to seeing you on the next episode.
Thank you for tuning in to Health Decoded, where we break down the truth about all things health and empower you to take charge of your well-being. If you found value in today's episode, please subscribe, leave a review, and share it with someone who needs to hear this. For more resources, personalized support, or to have your questions answered live on the show, visit Ascend Functional Health and head to the contact page to connect with us directly. Until next time, stay curious, stay empowered, and remember, your health is in your hands.